gynecologist, and I work in the unit with Dr. Eisenberg. And I would like to discuss issues of diagnosis and referral and suggest some treatment interventions that are non-medical. So women require different interventions at different levels of severity. And as Dr. Eisenberg mentioned, there are no consistent guidelines on diagnosis, referral, and treatment, which makes it very difficult to choose the right intervention for every woman. In our experience, in cases of moderate to severe fear, it is recommended to refer to psychotherapy. In some studies, fear of birth was considered moderate when 3 of the following variables were present: sleep problems and difficulty concentrating, physiological symptoms of anxiety or diffuse bodily pains, little or no insight into what the fear of birth represented, experience of a large degree of loss of control, and fear of dying during pregnancy or birth. Women who avoided pregnancy altogether, and we do meet women who come in at age 42 saying they want to become pregnant, but they're really scared, and that's why they haven't done it until now. So women who avoid pregnancy or initiate abortions or request C-sections due to their fear should also be referred for psychotherapy. There are very limited studies regarding interventions for fear of birth, unfortunately. Most of the studies come in from Scandinavian countries, and I don't know if any of you are from these countries. Maybe you can tell us more about it, but they have a system where they refer women who request C-section for consultations. So they do most of the research, and I want to present 2 studies. The first study randomized women into 2 groups. The intervention group received 5 sessions from an OB trained in cognitive therapy. The control group received 2 conventional treatment sessions that consisted of routine obstetric checkups. Both groups received written information about the pros and cons of vaginal delivery and C-section and pain relief offered at the hospital. So the results, both groups actually showed reduction in requests for C-section, which may be an important finding that just providing some more information about the pros and cons of C-section might help reduce these requests. In the intervention group, the duration of vaginal labor was actually shorter. It was 6.8 hours versus 8.5 hours. And the birth anxieties and concerns were reduced in the intervention group, but not in the control group. The second study, women were randomly assigned to 2 groups. The intervention group consisted of 7 group therapy sessions led by a psychologist. The control group received standard prenatal care by community nurses. Severe fear of birth was measured by a scale called the WDQ, and this is a validated scale for measuring fear of birth. The results, 63% of the intervention group had spontaneous vaginal delivery versus 47% of the control group. 22% of the intervention group had cesarean sections versus 32% of the control group. 36% of the intervention group had positive delivery experience versus 22% of the control group. So when referring for psychotherapy, you should consider the choices offered in your area or in your country. Usually you can find crisis intervention counseling or cognitive behavioral therapy. Both are, in our experience, might work well for these women. With cognitive behavioral therapy, there's a lot of information, a lot of research studies about cognitive behavioral therapy for specific phobias, which is pretty similar to tokophobia. This is a focused short-term intervention. It is the treatment of choice for specific phobias, and it has up to 90% clinical significant improvement in research trials for specific phobias, not specifically for fear of birth. Sessions range from 1 long several-hour session to about 12 weekly sessions. The cognitive behavioral model regards anxiety as having 4 components: the cognitive, emotional, physiological, and behavioral. So when a woman is encountered with a situation related to pregnancy and birth, she might have thoughts like, I will die while giving birth, or my body cannot handle pregnancy. Emotions such as fear, sadness, shame, physiological responses to increased heart rate, muscle tension, sweating, nausea, and fight or flight behaviors such as avoidance of pregnancy, termination of pregnancy, avoidance of birth preparation, and on the other end, obsessive search for information regarding pregnancy and childbirth. These actually increase anxiety, produce more negative thoughts, and intensify this vicious cycle. Understanding the unique components of this cycle helps choose the right treatment for each woman. Intervention in CBT include discussing fears and past OB experiences and traumas, psychoeducation for CBT, anxiety, pregnancy, and birth. CBT is cognitive behavioral therapy, so you actually tell them what the therapy is about, what we're going to do in this therapy. Reevaluating misconception regarding childbirth, this is very important, and talking about statistics and rates, exposure to the feared situation, and relaxation techniques. So for example, with escape and avoidance, the intervention will stress repeated exposure to the feared situation and a reevaluation of the cognitions that come out of this new learning. So when a woman is faced with an anxiety-provoking situation, let's say thinking about childbirth or even watching a movie with a woman giving birth, anxiety starts to rise. At some point, when the symptoms become intolerable, she escapes. She fears reaching the peak on the top, where she imagines something horrible would happen. Maybe an anxiety attack, which she's never had, but seems like it's going to be horrible, or fainting, or anything else, so something uncontrolled. But what happens is that it helps her reduce anxiety during at this point. But then what it does is that the next time she's faced with the same situation, anxiety is going to be higher. She's going to escape again, and this is just going to continue going on. Until gradually she starts avoiding more and more stimuli connected with pregnancy and childbirth. A part of cognitive behavioral therapy is actually systematic desensitization, and we would help this woman exposed to the fear, whatever she fears. While symptoms intensify in this session, we encourage her to persist until she reaches this peak, and she can see that the symptoms actually decrease on their own without her escaping. This whole cycle might take around 20 minutes. The next time she's exposed to the same situation, anxiety is not going to be as high, it's probably going to take less time. And then after several times, the symptoms are going to become tolerable, and she's going to be able to face those situations on her own. In our Women's Mental Health Unit at Tel Aviv Medical Center, we treat women with a variety of mental health disorders related to pregnancy and postpartum, as Dr. Eisenberg said. And as Dr. Eisenberg said, we frequently receive requests from women in the third trimester who are very stressed before their childbirth. It usually disturbs their daily functioning. In the unit, we provide focused interventions, such as the CBT that I just spoke about, or a crisis-oriented counseling. And this experience has led us to devise a single session protocol for fear of birth at term. We're currently researching this protocol, and at the pilot stage, we've been getting some good results of decreased fear on the STI, which is a measure of anxiety. We hope to continue seeing good results in the future, and maybe see some positive results on the birth process, and maybe even postpartum depression, mother-infant bonding. Thank you very much.
Sharon, yes, please go. You could go up there too. This is an important topic. And it's, believe it or not, a controversial one, at least in the United States. There would be women's advocates who would say it's too much. That if a woman says she doesn't want a cesarean, we should respect it and not bring out the psychological dimensions. How would you pursue this? And please, any advice you can give the doctors in the room. how do you discern if it's truly a pathologic fear that you can help, and you have results demonstrating you can help them, versus something that's really autonomous, that a deep found belief? Any advice you can give the obstetricians in the room?
I think the first point is to determine whether it's a disorder or not. We're treating disorders. Okay, so I think the first point is that you need to decide, you need to diagnose whether it's a disorder or not. When talking to somebody and seeing and understanding that it's his or her core belief that they don't want to give birth or have children, we don't touch that topic unless it causes any marital problems. Sometimes you get couples in which the husband wants to have children, the woman resists, and we need to understand why she resists. If she resists out of fear, in our perception, she's not being able to make a free-minded decision. If she's influenced by anxiety, she's not making a free decision, and then we offer help. We never make anyone have treatment, but we do offer our help. Once she's diagnosed as having an anxiety disorder, we treat it as an anxiety, whether it's a specific phobia or other anxiety disorder, we treat it as such, and then we can offer her several treatments, either pharmacological if she's not pregnant yet, or preferably psychotherapy if she's pregnant. That's how we address it.
Yeah, I want to say that you can't make anybody go through a psychological treatment like this, and they would need to want to do this. I think that for maybe for you, it's important to let them know that there's the option, and that possibly they can be helped and possibly can reduce their fear, and maybe even change their decisions, but they don't have to change their decision about the C-section. So I think it's just important to let them know that it's possible, and if they want it, then we can help them, or any other psychologist.
So just one more point that I guess we'll address it at the end of the panel is having questionnaires and using questionnaires either for research or clinically in the OBGYN office in order to help you to diagnose or at least screen for anxiety disorders, which is very important.
Do you have many women who refuse treatment?
Actually, no, our clinic is voluntary. So once a woman is referred to us, or usually they refer themselves, they come and ask for help. We don't have, usually women refuse medication and want psychotherapy, because once they're pregnant, they feel their fetuses, and before pregnancy, they feel psychiatric drugs. So
it's interesting for anybody from Scandinavia know anything about this? Maybe they can share their. Do you know anything about it?
Help us. You give us your